1, 2,
And review, female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
Let's start with
300 please.
I'll keep your card again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, usually when we talk about a medical diagnosis, there's this comforting expectation of precision.
Right. It's wonderfully binary.
Yeah, it feels like engineering. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, there it is. That's the problem.
Exactly. It's either broken or it's not broken. The treatment pathway is just a straight line.
But then you step into the world of obstetric and newborn nursing, and suddenly it feels like that x-ray machine is, completely useless.
Oh, absolutely. It's incredibly murky.
You are dealing with two patients at exactly the same time, and they are both undergoing massive, fast-paced, life-altering physiological changes. So welcome to today's deep dive.
Glad to be here.
Today, we are putting on our elite OB nursing educator and clinical mentor hats just for you. Our mission, we are going to aggressively apply the Pareto principle to newborn complications.
Right, and for those who might not use that term every day, the Pareto principle is the 80-20 rule. We have sifted through a massive stack of clinical protocols, textbooks, and research sources, and we are extracting the exact 20% of high-yield concepts that will, unlock 80% of your clinical understanding.
And your exam value if you're currently in nursing school.
Exactly.
Okay, let's unpack this. Because whether you are prepping for the NCLEX or getting ready to step onto the floor of the NICU for your very first shift, the sheer volume of material you are expected to know is, well, it's paralyzing.
It really is. You could spend weeks just reading about fetal circulation alone.
Right.
And as your clinical mentor today, I need to be incredibly clear about something right up front. You must stop trying to memorize random isolated facts.
That just doesn't work.
No, it doesn't. To thrive as a safe, prioritization-focused nurse, you need to start recognizing patterns. We are looking for patterns of safety.
So we have to train your brain to instantly distinguish between what is a slightly rocky but expected part of a newborn's transition and what requires immediate life-saving intervention.
Precisely.
So let's structure this chronologically. We are going to follow the newborn's physical transition to the outside world. We'll start with the literal first hurdle, which is their very first breath.
There is no higher priority. When a baby is born, the absolute most immediate concern is the airway. But here's the tricky part. Not all respiratory distress is created equal.
Right, because respiratory failure is the fastest way a newborn deteriorates. They just don't have the reserves an adult has.
They don't. And the interventions change drastically depending on the underlying mechanism. Understanding the why behind the distress is what separates a novice nurse from an elite one.
Okay, so let's break down the big three newborn respiratory issues that you will inevitably see. That's Respiratory Distress Syndrome, which is RDS, Transient Tachypnea of the newborn, or TTN, and Meconium Aspiration Syndrome, MAS.
What's fascinating here is how the clinical picture before the baby is even born, the gestational age and the maternal history, practically hands you the diagnosis.
Oh, totally.
Let's talk about what is expected versus what is highly concerning. A brief period of respiratory transition, maybe some mild tachypnea or fast breathing in the first 6 to 8 hours of life is, well, somewhat expected.
They are figuring out how to use their lungs for the first time.
Exactly. But if you see grunting, severe nasal flaring, central cyanosis, meaning their chest and lips are turning blue, not just their hands and feet.
Right, central versus peripheral.
Yeah. Or if you see subcostal retractions where the skin is sucking in beneath their ribs, that is highly concerning. That is active respiratory distress.
So let's back up to before the delivery. If a pregnant client comes in experiencing preterm labor, what are our priority nursing actions before the baby even arrives?
Great question.
The sources emphasize anticipating betamethasone for the mother. That makes sense. It's a corticosteroid to help mature the fetal lungs and boost surfactant production.
Right.
But then it also mentions anticipating magnesium sulfate. I always thought mag sulfate was exclusively for preeclampsia, to prevent maternal seizures. Why are we giving it for preterm labor?
That is such a common point of confusion. Magnesium sulfate is a smooth muscle relaxer.
Yep.
Yes, it lowers the seizure threshold in preeclampsia, but in preterm labor, it acts as a tocolytic. It relaxes the smooth muscle of the uterus, effectively slowing or stopping contractions.
Oh, so it buys us time.
Exactly. It gives that betamethasone time to actually work on the fetal lungs. But even more importantly for the fetus, mag sulfate provides fetal neuroprotection.
Wait, really?
Yeah, it significantly reduces the risk of adverse neurological outcomes like cerebral palsy for that premature infant.
That is a massive conceptual link. Okay, so then the preemie is born. Another thing that stood out in the protocols is that our target oxygen saturation for a premature infant is actually between 90 and 95%.
Yes.
My adult ER brain sees 90% and wants to crank the oxygen to 100% immediately.
And that instinct could permanently harm the newborn?
Really?
You have to remember that 100% oxygen is a drug, and it can be toxic. In premature babies, their retinal blood vessels are incredibly fragile and underdeveloped.
Oh, wow.
So flooding them with 100% oxygen causes those vessels to constrict and grow abnormally, which leads to retinopathy of prematurity and ultimately permanent vision loss.
That's terrifying.
It is. You want just enough oxygen to keep them safe, no more. And for a preemie, you should also anticipate the provider administering exogenous surfactant directly down an endotracheal tube.
Because that's what RDS really is, right? It's primarily a disease of prematurity. They simply haven't been in the oven long enough to make their own surfactant.
Exactly.
And surfactant is basically like dish soap inside the alveoli. It reduces surface tension so the little air sacs don't stick together and collapse every time the baby exhales.
That's a great way to visualize it. Now let's contrast that lack of surfactant in RDS with our second issue. TTN, or transient tachypnea of the newborn. TTN isn't a lack of surfactant. It occurs when there is delayed absorption of fetal lung fluid.
So if TTN is just retained lung fluid, is it basically like a sponge that hasn't been squeezed out yet because they missed the vaginal squeeze of a normal delivery?
That is exactly what it is. In utero, the lungs aren't filled with air, they're filled with amniotic fluid. During a normal vaginal delivery, the physical pressure of passing through the birth canal literally squeezes the baby's thorax.
Which forces a huge amount of that fluid out of the lungs and mouth.
Right. So who is at risk for TTN? Term or late preterm babies, especially those born via C-section, because they completely missed that crucial thoracic squeeze.
This makes the distinction so clear. RDS equals a structural immaturity, a lack of surfactant in premature babies. TTN is a mechanical issue-retained fluid in term or late preterm babies, usually after a C-section.
And here is an incredible safety priority for clinical practice. If you have a tachypneic baby, meaning their respiratory rate is greater than 80 breaths per minute, you must keep them NPO, nothing by mouth.
Because feeding a baby breathing that fast is a massive aspiration risk, right?
It's a huge risk.
They literally cannot coordinate the mechanics of sucking, swallowing, and breathing at that speed without inhaling milk into their lungs.
Precisely. Now, the third of the big three is MAS, Meconium Aspiration Syndrome. This happens when the fetus experiences severe stress or hypoxia in utero.
And that hypoxic stress causes their anal sphincter to relax.
Yes, they pass meconium into the amniotic fluid, and then if they gasp, they aspirate that thick, sticky, tar-like substance right into their lungs.
And because it's like tar, it causes severe mechanical obstruction and a massive inflammatory response.
Right.
So our clinical pattern recognition for the respiratory crises is simple. RDS is the premature baby lacking surfactant.
Right.
PTN is the term, C-section baby, with a fluid-filled sponge for lungs. And MAS is the stressed, often post-term baby with stained fluid.
Perfect summary. Now, if we zoom out from the airway, once the baby is breathing and that umbilical cord is cut, mom's supply line is officially severed. Now, the newborn's engine has to run on its own fuel.
Which is a huge adjustment.
Massive. Their next major hurdle is entirely metabolic. They have to regulate their own blood sugar and clear their own waste, specifically bilirubin.
Which brings us to a huge clinical focus. Infants of diabetic mothers, or IDM, and neonatal jaundice. These are highly tested concepts because the stakes are just so high.
They really are.
Hypoglycemia can lead to permanent neurological deficits, coma, and seizures. And severe jaundice can lead to crinteris.
Which is terrifying.
Yeah, where unbound bilirubin actually crosses the blood-brain barrier, staining the brain tissue and causing permanent irreversible brain damage.
They are absolute safety priorities. Let's look at the physiology of the infant born to a diabetic mother.
Here's where it gets really interesting, because I used to get this totally backward.
Oh, a lot of people do.
If a diabetic mother has poorly controlled high blood sugar throughout her pregnancy, why does the baby's blood sugar crash so dangerously low immediately after birth? You would logically think the baby would be hyperglycemic.
It is a brilliant question, and to understand it, you have to look at the placenta as a very specific kind of filter.
Okay.
Glucose crosses the placenta freely, but maternal insulin does not cross. So if the mother has uncontrolled blood sugar, the fetus is receiving massive continuous shipments of glucose.
Right.
To handle this huge sugar load, the fetal pancreas has to go into absolute overdrive, producing huge amounts of its own insulin to keep up.
It's like a factory that's hired thousands of extra workers to process a massive continuous shipment of raw materials.
Exactly. Now think about the moment of birth. The cord is clamped. That massive maternal glucose shipment stops instantly.
Oh.
But the newborn's pancreas doesn't get the memo right away. It is still operating at peak capacity, pumping out sky-high levels of insulin.
The result? Those thousands of extra workers. The insulin burn through whatever glucose is left in the baby's bloodstream in minutes.
Yes. We see rapid, severe hypoglycemia, with blood glucose levels dropping under 40 or 45 milligrams per deciliter.
The mechanism makes it so easy to remember. So, our priority nursing actions for an infant of a diabetic mother are clear. Perform a heel stick for a bedside blood glucose check immediately, and initiate early and frequent feedings to give that insulin something to process.
And you have to monitor sharply for the clinical manifestations of hypoglycemia. It doesn't look like an adult fainting.
What does it look like?
In a newborn, you will see jitters, lethargy, poor suck, hypertonia, meaning they are floppy, and a weak or distinctively high-pitched cry.
Good to know. Now let's pivot to that other metabolic hurdle, jaundice. What is expected versus what should immediately trigger a clinical alarm?
Expected is what we call physiological jaundice. This appears after 24 hours of life and usually peaks around days 2 to 4.
Okay, so a little later.
Right. It's essentially just the immature newborn liver struggling to catch up with the normal breakdown of fetal red blood cells. What is highly concerning is pathological jaundice. This appears within the first 24 hours of life.
So if you see a yellow tint to the skin or sclera in a 12-hour-old baby, alarm bells should be ringing loudly.
Very loudly.
That indicates a severe hemolytic crisis, like ABO or RH incompatibility. The red blood cells are being actively destroyed far too rapidly for it to be a normal transition.
Let's explore that RH incompatibility because it trips up so many people. The danger occurs specifically when the mother is RH negative and the baby is RH positive.
Right.
If their blood mixes, the mother's immune system sees that positive blood as a foreign invader and creates antibodies to attack it.
And usually the first baby is fine because the mixing of blood mostly happens during delivery. But the mother's body is now sensitized. She has an army of antibodies waiting.
Exactly.
If she gets pregnant with a second Rh-positive baby, those antibodies will cross the placenta and utterly destroy the fetal red blood cells.
Which is why our priority action is prevention. We give the mother Rh immune globulin, or ROGIM, to stop her from forming those antibodies.
And we give it a 28 weeks gestation as a prophylactic.
Yeah.
And again within 72 hours after birth, right?
Yes, to protect all future pregnancies.
And if a baby does develop dangerous levels of jaundice, regardless of the cause, our priority actions are early and frequent feedings because bilirubin is actually excreted through the stool, so we need that baby eating and pooping.
Spot on.
And we initiate phototherapy. The lights actually change the shape of the bilirubin molecule in the skin, a process called isomerization, so it can be excreted in water and urine without the liver needing to process it at all.
But for phototherapy safety, you must protect their eyes with special opaque patches.
Right, to prevent retina damage.
Exactly. You undress them down to just a diaper to maximize skin exposure to the light and closely monitor for insensible water loss. They can get dangerously dehydrated under those lights without you realizing it.
So we've covered the invisible chemical transitions, blood sugar and bilirubin. But what happens when the transition issue is blatantly visual?
The structural anomalies.
Yeah, we need to talk about anatomical anomalies that present themselves the second the baby is placed on the warmer.
These are your structural defects, and we're focusing on two major categories that require split-second nursing interventions. Abdominal wall defects, specifically omphalocele versus gastrocesis, and airway defects like esophageal atresia with tracheoesophageal fistula, or ETEF
Let's start with the abdominal wall defects. The visual difference here dictates the entirely different level of immediate danger.
It really does.
Omphalocele is when the organs are protruding from the belly button, but they are neatly packed inside a clear, protective peritoneal membrane. Gastroschisis, on the other hand, is when the bowel is spilling right out of the side of the abdomen with no protective bag at all.
I like to think of gastroschisis as a zipper on a jacket that got stuck halfway up. The contents are completely exposed to the elements.
That's a brutal image, but accurate.
Because gastroschisis has no protective membrane, the physiological cascade is terrifying. The risk of evaporative heat loss is astronomical.
Wow.
The moisture from the exposed bowel evaporates into the room air, plunging the baby into severe hypothermia, which triggers hypoglycemia, fluid shifts, and eventually hypovolemic shock.
So how do we stop that cascade? What is the immediate priority nursing action?
The moment you see gastroschisis, you must place the newborn into a sterile, clear bowel bag up to the exiliso, the armpits.
You literally put the lower half of the baby in a sterile drawstring bag.
Yeah.
That makes perfect sense. It traps the moisture, stopping the evaporative heat loss, and creates a physical barrier against infection.
And obviously, absolutely keep them NPO.
Right. Now let's look at the airway anatomy, EA and TKF. What does this look like clinically?
You will see a baby with excessive, frothy drooling, and the absolute moment they attempt the first feed, they will start coughing violently, choking, and turning cyanotic.
Esophageal atresia means the esophagus, which is supposed to be a tube leading to the stomach, ends in a blind pouch. It just stops.
Yes.
So whatever milk or saliva they swallow just fills up that little pouch and spills straight over into the airway. And the tracheoesophageal fistula means there's an abnormal tunnel connecting the esophagus directly to the trachea.
They are quite literally drowning in their own secretions, and every time they breathe, they might be forcing stomach acid up through that fistula into their lungs.
Priority actions.
Keep them NPO immediately. Elevate the head of the bed to 45 degrees to use gravity to keep the stomach acid down.
Yeah.
And insert a repilogal tube into that blind upper pouch.
Let's clarify what a repilogal tube is, because it's not just a standard feeding tube. It's a specific double lumen tube.
Right.
One channel provides continuous suction to constantly clear the pooling saliva, and the other channel vents air. If you just use a normal suction tube, the vacuum would suck the tip right against the delicate wall of the pouch and damage the tissue. The air vent prevents that.
That's a vital clinical distinction. Now, let me throw a highly tested structural scenario at you.
Okay, I'm ready.
Let's say you have a baby born in severe respiratory distress, and you suspect a congenital diaphragmatic hernia, or CDH. This is a condition where there is a hole in the diaphragm muscle, and the abdominal organs, the stomach, the intestines, have literally pushed up into the chest cavity, leaving no room for the lungs to develop.
Wow, okay.
What is the one intervention you absolutely never do?
Wait, if they are in respiratory distress, my basic life support instinct is to grab the bag valve mask and start forcing positive pressure air into them to oxygenate them.
And if you do that...
If I do that, well, the air isn't just going into the lungs, it's going down the esophagus into the stomach and intestines.
Exactly. And where are the stomach and intestines sitting in a CDH baby?
Inside the chest cavity. Oh, wow. If I pump air into the stomach, it will expand like a balloon inside the chest, completely crushing whatever fragile, compromised lung tissue the baby has left. I would actively be suffocating them.
Yes. You never use bag and mask ventilation for suspected CDH. You must immediately prepare to assist with endotracheal intubation, bypassing the esophagus entirely and delivering air only to the trachea.
That is a phenomenal example of understanding the why behind the protocol.
Okay, so we've looked at the baby's internal hardware and plumbing, but we can't ignore the environment they just came from, specifically what they were exposed to in utero.
Which brings us to maternal substance use, and specifically neonatal abstinence syndrome, or NAS, also referred to as neonatal opioid withdrawal syndrome, NOWS.
Right.
Withdrawal in a neonate is not just intensely uncomfortable, it can be fatal if the nursing team mismanages it. It requires strict control over their environment and highly specific pharmacological knowledge.
Let me genuinely push back on this, or at least share my confusion, because the protocols here contradict standard emergency care.
Let's hear it. Let's say a baby comes out completely limp, with severe respiratory depression, barely breathing at all. And we know from the chart that the mom is actively using high doses of opioids. In an adult ER, if someone comes in apneic from an opioid overdose, we slam them with Narcan naloxone immediately to reverse it. Why does the neonatal protocol explicitly forbid me from doing that?
It is entirely counterintuitive if you are used to adult medicine, but it is one of the biggest safety traps in obstetrics. Naloxone is an opioid antagonist. It doesn't just gently remove opioids, it violently and instantly strips them off the brain's receptors.
Right.
If you give naloxone to an adult who took too much fentanyl an hour ago, they wake up angry. If you give naloxone to a newborn whose central nervous system has been entirely built and developed in the chronic presence of opioids over 9 months, you will instantly trigger acute, massive withdrawal.
And withdrawal in a neonate isn't just shivering and sweating.
No, sudden withdrawal causes severe, intractable seizures and total hemodynamic collapse. It can be fatal. You treat the respiratory depression in that limp newborn with positive pressure ventilation and supportive airway care, but you do not push Narcan in a chronically exposed infant.
That is incredibly sobering. So if we are supporting them through withdrawal properly, what does NAS actually look like standing over the crib?
Everything in their central nervous system is firing too fast. They are hyperactive. You will hear a distinctively high-pitched, shrill, almost bird-like cry. They have hyperactive reflexes, constant tremors, and jitteriness.
It sounds exhausting for them.
It is. Their autonomic system is a mess, so their skin might be mottled. And gastrointestinally, they suffer from severe vomiting and diarrhea, coupled with an absolute inability to be consoled.
So our priority nursing interventions revolve around the ESC model. Eat, sleep, console. We have to violently decrease stimulation. You put them in a quiet, isolated room with low lights. You swaddle them tightly to give them physical boundaries, which helps calm their central nervous system.
And nutritionally, they need small, frequent, high-calorie feeds. The constant crying, diarrhea, and vomiting mean they are burning through calories and losing fluids at an alarming rate.
Right.
If those non-pharmacological interventions aren't enough to keep them safe, the protocols escalate to medications.
And ironically, the drugs of choice to treat opioid withdrawal are, well, more opioids. We use short-acting ones like morphine or long-acting ones like methadone, and then very, very slowly taper the dose down over weeks so the brain can adjust without seizing.
Exactly. The biggest mistake a new nurse can make is assuming a lethargic-looking NAS baby needs to be stimulated to wake up. They don't. They need the exact opposite. Minimal, gentle handling, clustered care, and profound quiet.
If we zoom out and look at everything we've covered today, we have navigated some truly dense physiological concepts. We've applied that Pareto principle and hit the absolute highest yield clinical scenarios.
We really have. And to make sure this truly sticks, let's distill this entire conversation down to the non-negotiable core. If you forget everything else we said, but remember these 5 things, you will be a vastly safer nurse.
Number 1, know your respiratory distress. RDS is a structural lack of surfactant in premature babies. TTN is retained lung fluid in term babies who miss the vaginal squeeze.
Number 2, watch the blood sugar. Diabetic mothers have babies who are at massive risk for sudden, severe, low blood sugar hypoglycemia under 40 to 45 milligrams per deciliter instantly after birth because their pancreas is still overproducing insulin.
Number 3, timing is everything with jaundice. Pathological jaundice is a hemolytic crisis that happens fast under 24 hours of life. Physiological jaundice is a normal transition issue that happens after 24 hours.
Number 4, for exposed abdominal wall defects like gastroschisis, your immediate absolute priority is to place the newborn into a sterile bowel bag up to the axilla. This prevents massive evaporative heat loss and hemodynamic collapse.
And number 5, the Narcan trap. Never give naloxone to a newborn chronically exposed to maternal opioids, or you will trigger potentially fatal withdrawal seizures. Ventilate them instead.
Those 5 clinical anchors will save lives. But as your mentor, I want to leave you with one final thought about the reality of this job.
Good stuff.
We spend years learning the pathophysiology of how to protect the newborn, but you also have to learn how to protect yourself. Working in obstetrics in the NICU means dealing with medically fragile infants, which means you will inevitably encounter profound grief, trauma, and devastating loss.
It's not always a happy environment. The sources we reviewed specifically dedicate time to secondary traumatic stress syndrome, or STS, and compassion fatigue among nurses.
Because it is a systemic issue. You are constantly exposed to the raw trauma of parents facing their worst nightmares. The clinical knowledge we discussed today is what gets you past the NCLEX and keeps the baby physically safe. But your empathy and your psychological resilience are what will actually sustain your career. The literature outlines the NRSE mnemonic for grief communication when you are standing at the bedside with traumatized parents.
Right. NURSE. Name their emotion. Understand and validate it. Respect their coping process. Support them by simply being present, even in the silence. And explore further by asking open-ended questions about what they need.
It is not your job to fix their grief. You can't. But your willingness to process that grief with the parents, and just as importantly, your willingness to debrief and process your own trauma with your colleagues, is what will make you an elite, lifelong nurse. You simply cannot pour from an empty cup.
That is such a crucial perspective to end on. The diagnostic landscape of OB nursing isn't a clean, broken or not broken X-ray. It requires you to navigate intensely muddy waters, balancing razor-sharp clinical prioritization with profound, vulnerable humanity. Keep applying these patterns to your studies, keep asking why behind the protocols, and protect your own peace along the way. You've got this.